Welcome to the 18th online meeting of our foundation. Today's talk should be of interest to everyone as the topic relates to an important organ in our body. Although most people keep worrying about their heart and lung, very few pay much attention to the kidney. It is an organ that keeps working non-stop 24/7, 365 days a year, removing waste and extra water from the blood and balancing various chemicals in the body. When it stops to function, you are in serious trouble. Unlike the heart and lung, when it starts to fail, we do not realize there is a problem until it is very late. The first time I heard about kidney failure was some 60 years ago, soon after we joined our medical college. One of the students, I still distinctly remember her name, Umarani, who had just joined. We were told that she was seriously ill with kidney failure and there was nothing anyone could do to help. Within a few weeks, she was dead. Those were the days when dialysis machines were not available in Madras, or for that matter, most of India. We have come a long way from there. Nagesh will today tell us a little bit about the modern trends of checking kidney function and how we can protect our kidneys so that they function well throughout our life. Dr. Nagesh is a student from Madras Christian College High School, the same school I graduated from. And he's a graduate of Stanley Medical College. He emigrated to USA soon after graduation. He did his fellowship in nephrology at Nassau County Medical Center, Stony Brook University in New York. He is both certified in internal medicine and nephrology. During the last 40 years, he has been practicing nephrology at Michigan. At the Henry Ford Allegiance Health, he has established a nephrology and dialysis unit. For the past 20 years, he has been deeply involved in the intensive care of nephrology patients. He had been managing the dialysis unit 24/7 for several years now. Nagesh also has an interest in the management of hypertensive patients. With his vast and wide experience, he will be able to explain everything there is to know about renal failure. Without any further delay, let me ask Nagesh to address our gathering.
First, have to thank the Madras Red Fort Doctors Foundation for inviting me and giving me the opportunity to help you understand about the kidneys and some new developments. I would have to ask Dr. Badri and thank him very much for his efforts. It's been a great honor to be associated with Badrinath and MMC. My connection to MMC is through my wife, who's also from the same batch as myself, 1967. I've been to MMC many times and know a lot of members of MMC 1966 and 67 batch and others through Dr. Badrinath and their friends in UK. Before I start, I would like to remind myself that my best friend, one Dr. V.T. Ramakrishnan, who is no more with us, was my best friend and in the same batch, 1967 in Madras Medical College. Because we cannot really cover everything within 45 minutes. So please bear with me because I may be missing quite a bit of what you don't know and quite a bit repeat some of what you already know. So any errors, please forgive me. My practice is exclusively nephrology and hypertension. I would like here to pay homage to my teachers. I completely studied in Stanley. The Dr. Somasundaram inspired me to become a physician. He currently is the dean or retired as the dean of Ramchandra Medical College. the late Dr. Jayanti Ramarao, who was an excellent teacher. Proud to say I'm one of his many students who learned clinical skills from him, which stood me in great stead in Jackson in the intensive care unit, where one cannot do an echocardiogram on a daily basis. Dr. M.P. Prabhakar, my chief in Stanley, who created an interest in hypertension, which I continued here in America. Quick review on the kidneys. As you know, most of us know that we are born with two kidneys. The kidney is like a black box. Blood gets into it and urine comes out. 1 in 1,000 people are born with one kidney. This is interesting because the solitary kidney is associated with uterine abnormalities. So people who have abnormal uteruses can also have abnormal kidneys. And most recently, we have found that it is a gene problem. It is called hepatocyte nuclear factor 1B, a big name. But for the medical students, the thing to remember is that if you have an abnormal gene, then you're likely to have the other manifestations, which in this particular condition is cystic kidneys and early development of type 2 diabetes. Somewhere down the road, there will be genetic screening. So if you have uterine abnormalities or a solitary kidney, then one should look for other problems. Next. A horseshoe kidney is an anatomical abnormality, commonly harmless, but rarely can cause obstruction. Like I said, the kidney is like a black box. Blood comes in through the afferent arterioles, comes out through the efferent arteriole. There's filtration in the glomerular capillaries, and then there is reabsorption in the tubules. And finally, there is the excretion through the distal tubule. The point here to remember is we filter about 150 liters at the glomerulus, but make only 1.5 liters at the distal tubule. And therefore, most of what is filtered is reabsorbed. And that includes glucose, sodium, potassium, urea, and many vital chemicals. And one can go through that in detail, but it would be like recap of physiology. Suffice to say that we are lucky because we are able to fine-tune our body's chemistries due to the function of the kidney. For the younger students, you may get bored listening to these in physiology, but believe me, every abnormality in the renal tubule, in the filtration part, is now genetically linked. We can actually study these genes using mouse models and create the same abnormalities in the lab, and that has helped us to understand the physiology much, much better. Renal disease is essentially trying to figure out why abnormalities occur. Kidney disease, congenital, genetic, and inherited, infective, and neoplastic. A quick run through. Congenital, as I said, you can be born with one kidney. We covered that. Inherited kidney diseases are constitute about 5 to 10% of people with kidney failure. Unfortunately, once you're born, you cannot change that, but you can screen your offspring, you can screen your siblings. The two most common causes of inherited kidney disease are polycystic kidney disease, now clearly documented to be due to two genes called PKD1 and PKD2. The other one is Alport syndrome. Infective kidney disease is usually as a result of post-infectious glomerulonephritis. It's much, much less, but now with the COVID epidemic and seriously ill patients, you can get post-infection glomerulonephritis, which is not, you don't see that commonly outside, but is known to occur. Then we have neoplastic kidney diseases, which is essentially renal cell carcinoma. It falls into the purview of the urologist. We just diagnose that. And secondary to others, which the next slides will show you, are a few. Next. The two commonest causes, of course, are diabetes and hypertension, which I will deal with in detail later on. The incidence of diabetes, I'm told, is around 30%, type 2 in Chennai. High blood pressure is very common. So the combination of two is what damages the kidney. Now, the kidney is like a black box, as I mentioned below. So the first thing we do is we want to check the structure of the kidney. Olden days, we used to do an IVP. It's no longer done because the CT has surpassed it. It used to be quite common to look at the pictures when we were doing rounds in Stanley, but nowadays the CT has taken over. An ultrasound is currently the screening test for kidney disease. Actually, right now, the medical students, by the time they are residents, will be doing point-of-care ultrasound, where an ultrasound probe is connected to their smartphone, and they will be taught how to do an ultrasound of a kidney. And it's a very good screening test. We do it all the time and commonly detects abnormalities. What we are really looking for is the size of the kidney and obstruction, because obstruction is a reversible cause of kidney failure. And you always want to make sure that there are two kidneys. The CT scan has replaced the IVP. Cystic disease of the kidney, stones are detected by the CT scan. In this slide, you see a large cyst. Polycystic kidney disease is also diagnosed by a CT scan or an ultrasound. An MRI is used to differentiate between infection and tumors because both of them show uptake. And when you have a cyst and you're doubtful whether it's infected, you try to do an MRI. A simple cyst, as documented in the CT scan, is very common. Most people around age 80 will have cysts. It's nothing to be of concern as long as there is no nodules or abnormalities inside the cyst. We rarely drain the cysts when we suspect infection or when there is some abnormality looking for any tumors, because there can be tumors inside the cyst, and an ultrasound guided needle we can get the fluid and send it for analysis. Kidney function is usually tested, as noted, by urine analysis. The old dipstick urine is still being done. The dipstick urine does tell us if there are any gross abnormalities. The dipstick one looks for protein, albumin, and glucose. The key to remember is the albumin, because proteinuria is a sign of kidney disease. The presence of red cells and white cells are also of concern. Persistent presence of red cells without any evidence of tumor or stones can be abnormal and the earliest indication of glomerulonephritis. White cells can indicate also nephritis. And in this last slide for chemicals, protein is most important. Nowadays, with doing blood glucose, urine glucose is not of concern. But please remember, people who take the new SGLT2 inhibitors will always show glucose in the urine, even though their blood glucose is normal. So you can sometimes be misled by the glucose and get concerned. You have to ask whether the patient is taking the medicine. SGLT2 inhibitors now commonly in vogue. The blood tests commonly used are the BUN and creatinine, which everybody knows, and I will come to those later. But one should remember that electrolytes are also fine-tuned by the kidney. The electrolytes are listed below, and we'll quickly go through one of them because each one of them has implications, which by itself will require a half-an-hour lecture to talk about abnormalities. Sodium. Please remember that sodium in the blood is a reflection of the water metabolism. It is not a reflection of total body sodium. Total body sodium goes up, you become edematous. But the sodium in the blood goes up or down. It really reflects the water situation. And two instances, high sodium, which is quite less common than low sodium. High sodium is commonly from dehydration and lack of access to fluid. Above 145, it can cause neurological complaints. And the first thing is, even by looking at them, you can make out that they're having a problem. And volume repletion or giving isotonic saline or intravenous fluids as your protocol will usually correct it. But persistent high sodium can be a sign of diabetes insipidus, especially in a neurosurgical or in an ICU situation where they're getting hyperalimentation, and that needs to be addressed. Low sodium is much more common, and it's getting commoner and commoner. It is a problem which can cause brain damage and even seizures and altered mental status. The commonest causes of low sodium are usually medications or endocrine disorders, or lastly, cancer of some type, or what we call the SIADH. It has to be diagnosed. Please don't ignore low sodiums and try to fix it. You first find out if there are any reversible causes and then treat it to make the patient better. Otherwise, they can suffer neurological sequelae and suffer even permanent brain damage. And there are some very bad complications by inappropriate treatment. So you do need to have somebody, an expert, who corrects the sodium, because rapid correction can cause a syndrome called osmotic demyelination, a terrible condition to occur. So there's something to remember, especially if you have family and friends who end up with this abnormalities. Potassium is regulated by the kidney and the hormone aldosterone. Low sodium is usually less than 3.5, it's 3.6 here. To unprovoked low potassium is abnormal. You do need to find out why. Years ago, we used to attribute it to surreptitious use of diuretics, but no, nowadays we do know that there are some tubular abnormalities which can cause low sodium, especially in young women. It needs to be looked at and can be treated and not dump them as anxiety provoking. High sodium is most commonly either from medication or kidney failure. Any potassium above 5.5 will cause problems. It manifests itself mainly by muscular problems, including muscular paralysis and bradycardia. And you do need to find out first why the potassium is high. But even before you find out the cause, treatment is absolutely necessary to prevent sudden death from hyperkalemia. A common cause of canceling surgery is potassium above 5.5, and you do need to intervene. There is a protocol in many hospitals of how to treat the high potassium, but one does need to look into the commonest medicine nowadays causing high potassium are ACE inhibitors and eating fruits, citrus fruits, especially while on an ACE inhibitor. The main markers of kidney function are BUN and creatinine. The blood urea nitrogen is dependent on your protein intake and the kidney function and the muscle mass. Eating a lot of protein can cause your blood urea nitrogen to go up. Also, blood loss in the GI tract also causes the blood urea nitrogen to go up. You can have a very normal blood urea nitrogen with advanced kidney failure if you're not eating anything at all. Creatinine is the common marker in 2021. Down the road, for the youngsters looking, there will be a new one called cystatin C. It's being worked on, but not yet approved. It's much more accurate. The limitations of the creatinine are that it's dependent both on the muscle mass as well as the kidney function. Here, one has to be careful, because if you're a very muscular person, your creatinine may be high, but your kidney function may be normal. At the same time, if you're a very thin old lady, your creatinine may be normal, but you may have advanced kidney failure. Also, race is important. In America, we have standardized it for Caucasians and African Americans. I am told that the creatinine calculated GFRs have to be adjusted for the East Indian population, and therefore creatinine is a good marker and needs to be followed, but not always very accurate, and it depends on the circumstances I mentioned about earlier. The commonest cause of kidney failure worldwide is type 2 diabetes. We in India are getting more and more of it. The funny part of it is that Indian diabetics are unusual because they're usually not overweight, and therefore they can develop diabetes type 2 as they get older. The latest hypothesis is that it's something to do with mitochondrial abnormalities. Dr. Mohan, the son of our Professor M. Viswanathan, has done a lot of interesting work on type 2 diabetes. The lab work is essentially shown it's a mitochondrial abnormality, and everybody recommends we take metformin. There are other drugs which I will talk to later, but a significant percentage of type 2 diabetes will develop the complications, even though their blood sugars are under control. Here, I want to emphasize that even though the sugars are under control, you can get evidence of renal damage. Why this happens, we have never figured it out. There have been various theories, a lot of work has been done, but we still don't know. Many years ago, Dr. Friedman, who treated our Chief Minister, MGR, used to say that we will fix it, but still it has never been fixed. So therefore, when you have type 2 diabetes, the best thing to do is to take preventive action from making the kidneys worse. Unfortunately, it doesn't work all the time, and the kidneys do fail as one progresses. Hypertension is the second most common cause, and we as senior citizens commonly develop high blood pressure as we get older. It is vital that you control the blood pressure and keep it 120 by 80. The old rule of letting it go up as you age is wrong. It is associated with a higher risk of stroke. So no, you cannot leave it at 160 and 150. It has to be down. I aim for at least 130, preferably 120. The diastolic has to be below 90s. The drugs of choice, which I shall mention later, just to give you two reasons, are usually ARB or angiotensin receptor inhibitors, or ACE inhibitors, or ARBs. One of the two drugs, the ARBs are better than the ACE inhibitors. Drugs also cause kidney failure. They start from the most nephrotoxic drugs, such as cisplatinum and amphotericin B, to the most common drug, which is non-steroidal anti-inflammatory drugs. Since many of us have prescribed or taken it, I would like to spend 1 minute here. Non-steroidals over the years have shown to damage the kidney in susceptible individuals. We don't know why only some people get the disease and not the others. This has been a dilemma because tons of people take non-steroidals and few develop kidney failure. So it has to be something individual. Secondly, some subgroups are more prone for damage, especially when they're taken in combination. For example, if you're taking a diuretic, you're more likely to develop some kidney damage. And it appears that people with hypertension and taking an ACE inhibitor may also be susceptible to damage. Now, why does this happen? It is due to intrarenal prostaglandins. The prostaglandin inhibitor, non-steroidal, also affects the intrarenal prostaglandins, and that seems to affect the circulation in the glomerulus and cause decreased kidney failure. Are there any safe non-steroidals? There is no absolutely safe non-steroidal, but some are less likely and some are more likely. We tell our patients not to take ibuprofen, which we think is the most common one. And if they have no choice, Sulindac is what we recommend, but that is notorious for causing gastrointestinal upset. Maybe someday there will be other drugs, but right now, oral non-steroidals, all are risky. Can you take the Voltaren gel, which is applied through the skin? Yes, probably. There is some absorption into the bloodstream, but it's probably much less than what it would be if you took it orally. Is this proven? No, it is not proven. But it is something to keep in mind if you can get away with taking topical Voltaren. Now, the fourth category down there is kidney diseases. We talked about the two most common causes. You can get out of the blue kidney disease, as we call it. Perfectly healthy people develop kidney disease. We don't know why. Many of them are immune complex diseases, and we still don't know why some people get it and why some people don't. And that maybe somebody watching as a medical student will try to figure it out, because there are a lot of young physicians from India doing research in many institutions working towards fine-tuning it. And here I should mention one, Dr. Sudhandaran at Cornell, who's played a great role in the treatment of kidney transplants. So he has young people working under him in basic research. So the commonest other disease causing kidney disease is lupus, very common in young women, underdiagnosed because many of the times people don't think about it, but it does. In olden days, it used to be pretty fatal, but now with newer treatments, most people can live with it without kidney failure for a long time. The statement Dr. Badri put up is very true. The problem with the kidney failure is that if you're not tested, you don't know. And therefore, it used to be common when I started, but nowadays we rarely see people in late kidney failure because everybody gets blood tests in their examinations. The early symptoms of renal failure are as listed. The most common, everything is a symptom, but very commonly we see people just complaining of asthenia, not feeling well, not eating well, and getting nausea in the mornings. These are very early symptoms, and they are some of the symptoms which bring you to test the patient. Why are these symptoms occurring? Vomiting with abnormal BUN and creatinine in the renal failure range means that you need to start the dialysis unless there is a reversible cause of worsening kidney function. The late symptoms are edema, as noted above. These are quite rare. Usually the edema and dyspnea comes in the fluid overloaded type of renal failure, very common in diabetics, and has occurred to even our prominent citizens in Tamil Nadu, where they present as heart failure, but they're really in renal failure and heart disease. A combination of renal failure and left heart failure causes massive edema. People anywhere up to 70 pounds or even 75 pounds can retain salt and water. And as you take the salt and water off with the dialysis, they significantly improve, and the left ventricular function also gets better. No names mentioned, but it has happened to some of our respected citizens in Tamil Nadu. Glomerular filtration rate, or eGFR as it's called, this is based on a serum creatinine calculated on age, race, and gender. I also mentioned the race earlier. The race has to be adjusted, and Indian conditions require adjustment for our East Indian muscle mass. They have shown that the Western eGFRs are not accurate for the Indian population. The limitations are already noted above. So I would suggest that each person know what their eGFR is and follow that, and then seek care depending on what you think is going on. If the eGFR shows a steady rise, yes, that is a cause for concern. The first thing you do is try to look for a reversible cause, and try to make sure that there's nothing correctable. And then you pursue management of the EGFR, which in most instances is diabetes control and hypertension control, and making sure you're not taking any toxic medication. Once you do that, then you sort of stabilize. Unfortunately, next slide, the EGFR decreases as you age. This is a calculation. This is done by the lab. Dr. Badri was glad to get it. I myself have forgotten how to do it. These are the stages of kidney damage. This is quite an interesting thing because this concept came into about 20 years ago when they did a massive study, and then they classified it into 4 stages. Actually, the most recent ones, there is a stage 3A and a 3B, 30 to 40, 59 to 45, and 44 to 15. Once you start going below 30, you are in significant trouble. Usually you want to intervene around 60 to try to take actions to protect your kidney. Now, if you're leaking protein and you're in stage 3, then it is of concern, because it is at that time that you undertake changes in therapy to protect your kidney function. Why do we do this? Because the problem is that EGFR goes down with age. This is unfortunately nothing we can do about it right now, at least in 2021. After age 40, for every 10 years, you lose 10 ml of EGFR. So somebody who's 80, who's got a normal creatinine, will still have an EGFR of only 40, even if he is perfectly healthy. Therefore, once your EGFR starts going down, you need to take preventive actions and try to do things to protect the remaining EGFR. Remember, we do not know when we are going to go to heaven. So as long as we're alive, we want to protect our kidneys and not end up on dialysis, which is not a good thing to do. So that's why the concern of intervening early and taking steps to protect whatever kidney function you have till the end of life. This is the slide which is tails in with the other one. Like I said, more than 60 is normal and less than 15 is kidney failure. But here I would like to remind people, don't go by the numbers, because there are people who are walking around with kidney EGFRs of 10 ml per minute, and we see them all the time. And if you ask them how they feel, they say perfectly fine, because their body is slowly getting adjusted to the toxins. As your kidney function fails, the toxin level accumulates. And we are wonderful human beings because our body adjusts to it. So you're slowly building up the toxins, but you're not getting sick. So just because you're 15 doesn't mean you need dialysis. You can do fine, because we do have senior citizens who are 85 and 86 who have kidney function of 10 ml per minute who feel fine. We're not going to do dialysis on them. We just tell them that if you feel fine, there's nothing to do. Just stick to your diet and see us very frequently. Now, in the earlier stages, if your kidney function's going down rapidly, then you need to make some changes and talk to your nephrologist as to what you want done. Remember, symptoms require starting of treatment. Numbers are there to guide you. You just don't go by numbers alone as far as the EGFR is concerned, but a drop is always of concern, because we want to rule out reversible factors and try to protect your kidney function as long as possible. And I want to emphasize the word as long as possible, because both diabetes and hypertension, being common causes, can be controlled, but they cannot be eliminated. This is a statistic brought up by Dr. Badri, and it's very, very true. Like I said earlier, a certain percentage will develop renal failure, and we're still working on it. The youngsters can look up the latest research. They actually think it's something to do with the basement membrane in the kidney, where there are products deposited in the basement membrane, which causes the kidneys to fail. There have been some drugs tried, but unfortunately, the drugs made things worse. Some of them developed kidney failure earlier. Others ended up in heart failure. So the drugs were pulled by the FDA. And I have been sort of following this literature because it is a very common cause. Nearly 70% of my patients' cause of being on dialysis is kidney failure. A quick run through. As you can see, there's a normal and there's a diabetes. The problem is that the efferent arteriole, as you can see on the right-hand side, is vasodilated. And that's what causes the problem with the glomerular filtration. And it is at the efferent arteriole that the ACE inhibitors work. So therefore, ACE, ARB, the emphasis on controlling the efferent vasodilated arteriole to protect the kidney as much as possible. There's one slide is missing, but I have to point out with the new drugs, Dr. Murali, I think, gave a talk earlier on SGLT2 inhibitors. In the proximal tubule, right after the glomerulus, there are two SGLT1 and 2. The 2 is responsible for nearly 80% of the glucose reabsorption, and the new drug SGLT2 blocks it there and therefore causes you to lose glucose in the urine. It is a mimic of the old renal glycosuria, where you have normal blood sugar but positive urine sugars. This loss of glucose in the urine causes you to lose weight and seems to protect the kidneys. There are two other things to remember. The SGLT2 inhibitors have become the standard of care. Very recently, in 2021, there have been a couple of studies which show that they're also very protective of the heart and prevents heart failure. So right now, we as a standard recommend people take SGLT2 inhibitors for type 2 diabetes as long as their eGFRs are about 30 ml per minute. So the combination treatment, you control your sugar by whatever you are doing, but do take an SGLT2 inhibitor, period, no matter what. So that's the current thinking at this time. There is a very rare complication of SGLT2 inhibitors, which is called euglycemic ketosis. When we started doing that, we saw one patient, and we are totally puzzled because they are not type 1 diabetics where there's an insulin deficiency and prone to ketosis. They have insulin on board. So why are these people developing ketosis? And we were totally puzzled, but after treatment, we reported to the FDA. And lo and behold, about 6 months later, it was reported in literature that this is a known complication due to the alteration of the glucose metabolism in the liver. So right now, that's the rare complication. Commonly, people develop urinary tract infections or yeast infections. So that's the main side effect, but it does seem to protect the kidney, does seem to cause a lot of loss of weight, and does result in polyuria. You do keep going to the bathroom frequently. High blood pressure, as noted, it is the second most common cause of renal failure. I have always been interested in it since my Stanley days. No, the kidneys are not the only cause for high blood pressure. The kidneys do get damaged from the high blood pressure. They can be a cause for the high blood pressure, but they are not the only cause for high blood pressure. This was clearly pointed out to me by my residency days when my chief told me, "Why do you think this patient has high blood pressure when he has kidney disease?" And I said, when he was on dialysis, and I said, "He's got kidney failure." And he says, "He has no kidneys." So I have taken both of it out, and he still got high blood pressure. So that put an end to the theory that the kidneys are the cause of high blood pressure, because there are other causes for high blood pressure. And since 1975, when I left India, there have been numerous medicines, better medicines, excellent medication, but we still have people with very severe high blood pressure who take at least 3 or 4 drugs to get the blood pressure down. So there is no answer to all the causes of hypertension, but hypertension needs to be controlled. There is clear evidence that control of blood pressure decreases the rate of worsening of your kidney function, clear evidence that it prevents stroke and myocardial infarction and vascular disease. The first drugs of choice in 2021 are usually ACE inhibitors and calcium channel blockers. The old theory of starting with a thiazide diuretic and adding is out the window. You usually start now with an ACE or an ARB, a calcium channel blocker. You add a beta blocker if there is heart disease and try to adjust it, and add the diuretics depending on the eGFRs, because if you're below 30 ml per minute, the thiazides are not going to work, and it's a waste of time. So therefore, seeking care in manipulating the medicines is the best way to control high blood pressure. There are a few people who have very severe high blood pressure on 4 or 5 medicines, and that's we as a nephrologist find challenging and try to help them. And in my experience, there is nobody's blood pressure you cannot control as long as you get the right combination of medicines to control the blood pressure and make sure there is no underlying cause for the high blood pressure. The most common ones missed are renovascular disease and endocrine abnormalities, which nobody thinks of till it's too far gone. Now, coming to the treatment of CKD, we talk about medicine. There is no specific medicine for treatment of kidney failure, but it is, as pointed out, control of blood sugar. Like I said, a talk was given by Dr. Murli earlier. He emphasized the use of various drugs to control the blood sugar. A couple of tips here. First, metformin, commonly used. They used to be afraid of lactic acidosis, but no, we are not that much concerned now because it's quite rare. Until their eGFRs are down to 15 ml per minute, we prescribe the metformin. It used to be 30 ml per minute, but they have lowered it down to 15 ml per minute. But the key to note about metformin is if you get sick, meaning nausea, vomiting, unable to eat or keep food, stop it. Wait till you get better and then restart it. Don't keep taking it when you are ill, because that's when you get into trouble with lactic acidosis, which can be fatal. I talked about SGLT2 inhibitors, same thing, take it. You can take it up to 30 ml per minute, keep your sugars under control. Once again, you can take it in combination with an ACE inhibitor. The biggest precaution again is if you're feeling ill, stop it first. We recommend you stop the SGLT2 inhibitors if you're going for surgery and any place where you don't have access to salt and water, like you're in a post-anesthesia when your thirst mechanism cannot be fulfilled, and you will tend to get dehydrated because of simple physiology. You're losing glucose in the urine. Glucose in the urine acts like a diuretic. It drags out salt and water and therefore decreases your blood pressure. So if you don't have access to salt and water, don't take it. High blood pressure, we just talked about it. ARB and ACE inhibitors aim for 140/80. Here, sometimes there's a misunderstanding saying that if your blood pressure is high and you bring it down, I'm feeling symptomatic. Yes, the body has to adjust to low blood pressure from a high blood pressure. It is very common for a person whose blood pressure is 160/110, when you bring down to 140/90, even though not perfectly controlled, for him to complain of dizziness because the auto-regulation is not yet complete. It will take some time for his body to readjust itself to a lower blood pressure. It does not mean you're going to have to leave his blood pressure as 160. That's wrong. You have to bring it down and carry him through, holding his hand till his blood pressure is down to 140/90. The other thing you have to look for, especially in senior citizens, if they are getting dizzy, is are they having any carotid disease? Because when you're getting your blood pressure down, you're not perfusing the carotids and you're going to get dizzy. So 140/80, 120/80 is the control, at least 130 if you can do it, and that will help protect the kidneys and decrease the stroke, etc. I also talked about the thiazides and loop diuretics and the restrictions on them. And there are some instances where these don't work. And that's where you have to send them to somebody who does control of blood pressure, what we call resistant high blood pressure on 4 medications, not coming under control, and they can work them up for secondary hypertension and endocrine disorders. Dialysis is something I do and I've been doing for the past 40 years till I retired. It is something nobody wants to put people on. Dialysis is a last, and I repeat, last attempt to keep people alive. Can people live on dialysis long? Yes. It depends on their genetic makeup and how well they take care of themselves. The longest patient I've had on dialysis is about 35 years. And that is an exception rather than a routine. In America, the mortality rate is somewhere around 20% or even 18% per year, which means out of 18% of our dialysis patients die every year. So that's why you don't want to be on dialysis, and you want to delay the dialysis, and I emphasize the word delay, as long as possible. Peritoneal dialysis and hemodialysis, there's a slide on peritoneal dialysis. This was what we did in Stanley. The famous Dr. M.K. Mani, currently, I don't know, he's retired at Apollo, did it, and we were all fascinated that one could do this. And his assistant continued it on our respected chief ministers and the etc. It was the treatment available. Nowadays, we do it what is called continuous ambulatory peritoneal dialysis. This can be done at home. It's not a complicated procedure. It is the procedure we recommend for people who can do it, who have some evidence, who are clean, because infection is a big danger, and who want to keep functioning. So peritoneal dialysis is actually better because it protects the kidney and has less fluctuations of blood pressure. And especially if you're going to go get a kidney transplant, it protects what we call as the residual renal function, which is still there when you are in advanced kidney failure. There are some doctors in Chennai who do this, and one of them actually is a well-known expert who happens to be our friend, but he's been trained in Toronto where they started it, and he still continues that with great success. Hemodialysis or a kidney machine, very simple slide, you get blood out, blue arrow, clear it through the dialyzer and get it back in. The usual treatment is 4 hours, 3 times a week. Yes, it keeps you alive. Yes, you get a reasonable quality of life. With the newer medication and good blood pressure control, you can live long. Actually, now in America, we try to do this at home. There are new machines which are as big as a suitcase, a carry-on. You can do this at home. All you need is a helper. You can put the needles in. You can do the dialysis, and you can do it at your convenience, but you have to do it a little more frequently. Maybe an hour, hour and a half. Most of our patients are watching the news or their favorite comedy show while they hook themselves on. And it is a safe treatment. It is better than coming to the dialysis center, and it keeps your blood pressure under control. It increases your appetite and prolongs your life. Home hemodialysis is preferable to in-center hemodialysis, like this young man is lying down, because the results are much better. But unfortunately, not everybody has the right situation where they can do it. The most common is, oh, I can't do it. Oh, I'm afraid of needles. I can't put the needles in, or my wife doesn't want to do it. Those are the usual reasons. But otherwise, home hemodialysis is better than in-center hemodialysis to keep people going. Transplantation is the best treatment for kidney failure. Once again, transplantation is the best treatment for kidney failure. When do you do it? We call it preemptive transplantation. If you're down to about 20 ml per minute, then it's time to look, find a donor if possible, or get on the list, which we do in America, because there's a waiting time, and then get a transplant. The transplant rates are extremely good, and therefore you should go for a transplant whenever you can. The best is, of course, as pointed out by the slide, living related. Wife, brother, sister is fine. The commonest donor here is usually brothers or sisters. Then it's usually the spouse. Good-hearted persons also donate kidneys here. So there are some altruistic donors who do give kidneys. That's wonderful. And we still have a big shortage of donors. Cadaver kidneys, yes, good, but not as good as a living-related. The survival rate is slightly less than a living-related donor. And we think it may be as a result of the prolonged donor time from getting the kidney from the cadaver and putting it into the donor. Whereas in a living-related, the donor and the recipient are in two different operating rooms. They take the kidney from the donor, move it across the hall into the recipient, and then you're done. So the amount of time you're not connected is only in minutes. Whereas in cadaver, it's long, and it may be one of the causes of a slightly poor survival rate. Now, recently, you may have seen in the news, they are doing preliminary studies on xenotransplantation. These are usually pig kidneys. They have humanized pig kidneys. Cambridge, England has been working on these pig kidneys for a long time. And here they recently did an experiment, actually, where in a brain dead person, with the consent of the family, they took a pig kidney and kept it on the thigh and connected the artery and the vein to the patient, and then looked at the urine flow and the chemistry. It has not yet been published in a reputed journal like New England Journal or Lancet, but this is the future, because if they are humanized pig kidneys, then that is a possible fix. This will probably happen outside America or Europe, maybe in some other places first, and then maybe in the time our young medical students become specialists, this may become routine. But once again, xenotransplantation brings up the possibility of zoonosis. We are just going through COVID, so you don't know what other infection is in that pig and what you're going to get. So that is a big fear in xenotransplant, and there are going to be some heroic people getting the first kidneys. Now, the last slide is really a recap on what one can do for protecting your kidneys, which is what we talked about. We emphasized it again quickly to run through: sugar control, keep your hemoglobin A1Cs as low as possible, use SGLT2. This is specific to the kidneys. I'm not talking about the whole diabetes type 2, which has already been addressed in one of the previous lectures, but specific to the kidneys is the SGLT2. Blood pressure control, once again, ARB or ACE inhibitors, drugs of first choice. They are specific to the kidney and protect the kidneys. The calcium channel blockers dilate the blood vessels, but don't have renal protection. Reduce protein intake. Yes, this is a standard of care. They have shown very clearly in experiments that eating high protein damages the kidney and eating low protein protects the kidney. Additionally, eating low protein seems to increase longevity. So plant protein is better than animal protein. Why does it do that? It appears that increasing the protein intake increases renal blood flow, which in damaged kidneys is actually bad. Next is restrict salt intake. Yes, both for high blood pressure as well as to prevent fluid retention, you want to cut your salt intake down. There is very, very rare conditions where you can increase your salt intake, and those are called usually interstitial renal disease, but that's so rare, so don't buy anybody telling you that you have to eat more salt. That's highly unusual. Another common mistake is eating more salt when you have hyponatremia. That's actually the worst thing to do, because all you will do is make things worse by retaining salt in water. We talked about avoiding non-steroidals, specifically as much as possible. Unfortunately, as you get older, we have arthritis, nobody can do anything, and we end up taking it. So if you end up taking it, make sure you get regular kidney function tests. First, my rule is take it for 1 week, check a creatinine, 1 month, one more time, 3 months, one more time, and then every 6 months. So as long as the creatinine doesn't go up and you're a high risk, meaning you're taking an ACE inhibitor, an SGLT2 inhibitor, then you need to follow the creatinine. Low protein diet is really to prevent arteriosclerosis. As you get older, increased fruit and vegetables is once again general dietary recommendation. Please remember, as your kidney function decreases, eating more fruits, especially high potassium, may be a problem. Eating fruits when you're on an ACE inhibitor may be a problem. So if you're eating a lot of fruit and staying on an ACE inhibitor, you have to worry about your potassium. The commonest manifestation of high potassium without checking the blood test is muscular weakness. When you suddenly start feeling weak or you start feeling slow, lack of energy, it could be from the high potassium. Oh, this is just for fun. I live in Michigan, a very cold place, but the town I've been here 40 years, 20 years solo, 24/7, 365, and 20 years with a partner. I just retired last year. Yes, it is cold here, but we don't have tornadoes. We don't have floods. We don't have earthquakes. All we have is snow. Last slide, a little bit personal. I fly planes, and that's my hobby. And I'm flying over Detroit, Michigan. And we have a wonderful state, except it gets damn cold in winter. Thank you.